Hi, I'm Dr. Jerry Hesch, a orthopedic manual physical therapist. I work at Hesch Institute in Aurora, Colorado, and I have a bachelor's in PT, and I was still confused, so I got a master's in the 90s, and that was in healthcare with emphasis on physical therapy, and then a clinical doctorate. This presentation is on hyperflexed coccyx, and this accompanies a course, an online course on the tailbone, and there are some proposed mechanisms of how this might occur due to altered posture in someone who gains a lot of weight. But there are many other ways to induce a forward bent coccyx, and sitting on a low sofa is certainly a way for the pelvis to tilt backwards, and then you impart more pressure on the tailbone and it can push inward. Childbirth can initially push the tailbone posteriorly to increase more space in the birth canal, and if the force is excessive such that it may stretch or tear ligament, then after the baby is born, tension in the pelvic floor could bring it into hyperflexion. It's a difficult pattern to treat, and the literature is very clear on this. The more the pain and the more the duration of the pain, the greater the severity of pain, the less likely it is to respond to manual treatment. And I do inform my clients in advance that a forward bent, pushed inward tailbone is one of the most difficult ones to treat. But if there is a side bending or rotated pattern, or if it's hyperextended, those respond better to manual care. So I will show you technique, and let us assume that for whatever reason, this person has a hyperflexed tailbone. You may be able to do an external forward spring test by putting your hand on the sacrum, dropping your middle finger, bending the distal part, and you should find the tip there. Now, in some people, it's quite, very much more anteriorly, okay? So anyway, you can form with your middle finger, you can follow the outline of the tailbone, and you can then impart a little bit of an impulse to increase the forward bending. And if that is a positive sign, and the patient has more discomfort, then that is one of the indications for a trial of mobilizing it externally. Now, I have another video link where I demonstrate treating it externally, and sometimes you're actually able to hook it externally and then bring it posteriorly at the same time, trying to get a little bit of traction. A little bit tricky, but it can be done. This presentation are on those in which it's not accessible externally and you do need to go internally to capture it. Okay, so in your clients, you're going to make your client aware of the fact that you are going to remove the sterile glove. You're going to establish a sterile field, okay? And before you put on the glove, this will be our sterile field. Okay, so I haven't touched anything, all right? And then you're going to clean your hands very, very thoroughly, okay? Prior to that, you would open up the lubricating jelly and put it within the field there. So then you get your glove on. Okay, I'm right-handed. You would explain the whole procedure. There is a consent form you can sign. It's within the paperwork for the online course. And you put the glove on, and the person is draped. Okay, regardless of who they are, what their comfort level is, whatever, I drape them. That's what I do. So then I would come underneath the towel, okay? And I ask for their guidance, but it is now done with the index finger. And so I'm going to put a little pressure on the sphincter, getting feedback from the patient. And I'll say, do you feel like I'm on the sphincter? Okay. And I impart a little bit of anterior force, ever so gentle, because if you can be very gentle, the body is not going to feel threatened, and the body will gain the body will give you cooperation. Okay. So I just impart a slow pressure, and it may take me a full minute before I enter in through the rectum and then curve my finger underneath and attempt to hook underneath the tip of the tailbone. You'll read some people's writings, such as James Monell, 1952. He was the father of John Monell. And in the writing, it makes it sound so simple, but different people have different angulations. And for some people, it's just incredibly difficult, okay? But under an ideal circumstance, you would be able to get underneath the tip, okay? So my index finger would look something like this. I hope that's easy to visualize, okay? But, okay, so let's pretend my index finger's on the tip of the tailbone with my thumb or my index finger of my other hand or the outside of the heel of my hand. I want to get some inferior traction, okay? Or perhaps I use the thumb externally and I traction the tailbone inferiorly towards their feet. And I do that for a whole minute. I really want to maximize the separation primarily at the sacrococcygeal joint, okay? And after I do that for a minute, then I'm going to lift up with my index finger up towards the ceiling, so I am then attempting to extend the tailbone, okay? Now, it is my belief that most people who have pain with an injury inducing a forward bent tailbone, most of the time it does involve the joint between the sacrum and the first coccygeal segment, okay? But there are examples in the literature, and there is imaging in the literature that shows you that a person can actually have a subluxed lower coccygeal segment. And Monell talks about capturing one segment at a time, distracting it, gliding it forward and backward, side to side, and then rotating left, rotating right. Also, he talks about extending it and flexing it. And doing all of those movements may give it the opportunity to right itself. But I must add, it's, in a lot of clients, it's extremely difficult to say, gee, I'm on the fourth coccygeal segment, and now I'm on the third, and now I'm on the second, and now I'm on the first. Sometimes it's just really difficult to get in there. I wish it were otherwise. I wish there was a nice bolt there with a handle and I could pull each segment, you know, that would be lovely, but reality is otherwise. But if you're able to articulate one segment at a time, more power to you. You might be very helpful for some of these clients. But sometimes it is simply too difficult for me to access that. Now, if it's a female client, referring them to a pelvic floor therapist may be ideal. They may be able to access that anteriorly. And you may want to just establish that you're both on the same page about believing in the importance of distraction for at least a minute before extending it. And the pressure that I apply once I've done the setup and I've done the distraction, the force that I apply to extend it, lifting finger up towards ceiling, is going to be 3 minutes. I feel like this is my one opportunity to make a difference, and I want to give it my best effort. And then when I come out of it, I want to come out slowly and just tell them what you're doing and say, okay, I'm finished now, and now I'm going to come out. And you might not always, as a clinician, know if you were effective or not. You may not have felt something move. It may take a little bit of time, maybe more than a day, for the client to actually give you good feedback. It is what it is. It's a challenging diagnosis. And thank you very much.